Welcome to the Deep Dive, the show that cuts through the noise, distills the essence of complex topics, and gets you straight to the most important insights. If you've ever faced the challenge of guiding a patient back to peak athletic performance after knee surgery, especially something like an ACL reconstruction, well, then you understand the incredible demands and the high stakes involved. The journey isn't just about healing, it's about meticulously rebuilding strength, power, and crucially, confidence. Today, we're taking a deep dive into an indispensable tool for that journey, the precise and really powerful role of isokinetic testing and training, specifically for knee extension and flexion in ACL rehabilitation.
That's right. Our mission today in this deep dive is really to equip you, the dedicated sports medicine professional, with nothing less than a masterclass. We want to provide a step-by-step guide so you can confidently implement isokinetic protocols. We'll walk you through every phase, from those delicate early post-op days all the way to that hopefully triumphant moment of full return to sport. We're talking about achieving unparalleled precision in your assessments, consistently maximizing patient outcomes, and just ensuring that every single clinical decision you make is robustly backed by objective, quantifiable data.
Absolutely. And this isn't just about understanding the what of isokinetics, that will certainly cover the fundamentals. It's really about delving into the profound why behind these protocols, why they've actually seen a resurgence in modern rehab, and most importantly, the practical how. How do you apply them? Our goal is to empower you to make those truly critical clinical decisions at every single step of the rehabilitation journey, moving you beyond just being informed to becoming, well, genuinely insightful. We're primarily drawing from a really comprehensive resource that focuses on the indispensable role of isokinetic testing and training after ACL injury and reconstruction. But we've also woven in insights from other cutting-edge, evidence-based protocols and general principles to give you a truly holistic and actionable deep dive. Hashtag the foundation of isokinetics in ACL rehab. All right, let's unpack this a bit. When we talk about ACL rehabilitation, it's certainly not a static field, is it? There's been a fascinating evolution. How exactly have the approaches shifted over the decades? Getting patients back on their feet and confidently back into the game.
Oh, it truly has been a dynamic journey. It really reflects our evolving understanding of knee biomechanics and graft healing processes. If we cast our minds back to the 1960s and 70s, the approach was actually quite integrated. It embraced a mix of open kinetic chain OKC, where the foot moves freely, isolating a joint, and closed kinetic chain CKC, where the foot's fixed, like in a squat, engaging multiple joints. Functional rehab was in there too. Then, moving into the 1980s, we saw the peak usage of OKC isokinetic testing and rehab. This surge was largely driven by a growing body of scientific literature that really supported its effectiveness for specific strength and power development.
Okay, so a strong emphasis on the very tool we're discussing today. What led to its decline then if it was so prevalent and, well, seemingly well supported?
Precisely. But then came the 1990s, and with it, a pretty significant paradigm shift. The clinical focus moved almost exclusively to CKC exercises. The thinking at the time was that CKC was inherently more functional because, it mimicked multi-joint weight-bearing activities. This trend, really emphasizing functional rehabilitation and these multi-joint exercises, continued right into the 2000s. However, the current trend, really solidifying in the 2010s, represents a return to that original integrated approach. It acknowledges the synergistic benefits of combining OKC, CKC, and functional rehab. It's almost like we've come full circle, driven by new data and insights.
That's quite a pendulum swing. It's genuinely surprising to hear that isokinetics saw such a decline, especially you mentioned how much literature supported it even back then. Was there a perceived drawback or maybe a misunderstanding that sort of dominated the thinking?
That's a really crucial point. Despite this extensive body of literature supporting its clinical use, we're talking approximately 2,000 articles just in the 1990s, and now over 6,300 references on PubMed, with more than 3,000 focused specifically on knee testing and rehab. Despite all that, many clinicians did move away from it. A major reason for this shift, which we're now kind of recycling back from, is realizing that those 20-25 years with the heavy CKC and purely functional emphasis, well, they might have inadvertently left critical components unaddressed, strength and power development. The focus became movement patterns over isolated capacity, and that proved to be a significant blind spot for many patients.
Okay, here's where it gets really insightful. There's that meta-analysis by Ardern and colleagues, real landmark study. It revealed that only about 55% of patients actually returned to their pre-injury activity level after ACL reconstruction. What does that stark finding tell us about that previous sort of singular emphasis on CKC?
That finding is profoundly telling, isn't it? It really underscores the limitations of going only with CKC. It suggests that CKC-focused rehab, while definitely valuable, may have failed a significant portion, 45% of patients, in reaching their full athletic potential. And crucially, that study identified quadriceps strength as the primary modifiable risk factor, the thing we can actually change that directly influences return to play. And this isn't just about raw strength numbers either. It's a stark reminder that if we blindly chase only a limb symmetry index, an LSI, mainly using CKC exercises, we might be missing the critical elephant in the room, bilateral weakness.
So they look symmetrical, but both sides are actually weak.
Exactly. A seemingly good LSI can absolutely deceive you if both limbs are equally deconditioned. The patient is symmetrically weak, but functionally unfit for high-level sport, and recent systematic reviews really reinforce this. They conclude that, and I quote, neuromuscular exercises should not be performed to the exclusion of strengthening and range of motion exercises. This just highlights the essential need to strengthen each individual link in that lower extremity kinematic chain. Build a robust foundation before advancing. It really emphasizes why ignoring a powerful, precise tool like isokinetics might have contributed to those lower return to play rates we saw for so long.
Right, so given this history and the clear need for precise strength assessment and development, what does isokinetics truly mean for us as clinicians? And how does it uniquely stand apart from other forms of resistance training we might use?
Okay, so at its core, isokinetics describes a muscle contraction that happens at a preset, fixed angular velocity. Think of it like a machine acting as a governor, maintaining a constant speed. Could be super slow, like 1 degree per second, or really rapid, up to maybe 1,000 degrees per second. But what makes it unique and incredibly powerful is that it provides accommodating resistance throughout the entire range of motion, the ROM. This means the resistance the patient feels exactly matches the active muscle force they produce at every single point in that movement.
So completely different from lifting a fixed weight, where the resistance is constant, but you might be stronger at some points than others.
Precisely. When you lift a fixed weight that's isotonic exercise, the resistance is fixed, but the velocity of your movement will vary. You're only maximally loading the muscle at its weakest point in the range. Isokinetics, because it accommodates, allows the muscle to be maximally loaded at every point. It accounts for those natural changes in biomechanical leverage and muscle link tension. That's a critical advantage for really comprehensive strengthening. And isometric testing, just to be clear, that's static. No movement, just holding a contraction at a fixed angle.
This accommodating resistance sounds incredibly powerful, especially for rehab. What are the key benefits we should be thinking about for our patients, particularly in ACL recovery, where precision and safety are just paramount?
The advantages are numerous and they're quite compelling, especially in a delicate situation like ACL recovery. First, and fundamentally, isokinetics provides objective and reliable data. We're talking quantifiable proof of dynamic muscle performance. That's absolutely crucial for tracking progress, communicating effectively with patients and other clinicians, and making truly informed, data-driven decisions about progression. Second, it's remarkably efficient and inherently safe. Because of that accommodating resistance, muscles get loaded to their max capability through the whole ROM. Yet the patient never meets more resistance than they can actually handle. The machine only gives back what the patient puts in, force-wise. This makes it incredibly safe even for patients early on where protecting that healing graft is the absolute priority.
Yeah, that safety factor has got to be huge, especially when you're trying to push for gains, but you absolutely cannot risk the graft.
Absolutely. Another key benefit is muscle isolation. Isokinetics lets you target assessment and rehab for specific muscle groups like the quads or hamstrings without compensation from other joints creeping in. And surprisingly, maybe, concentric isokinetic exercises produce minimal post-exercise soreness, or DOMS. This is a significant advantage. Less soreness helps massively with patient compliance and allows for more consistent, maybe even more frequent training sessions, which can accelerate recovery. But beyond just raw strength, it really shines in power development.
How so? How does it build that explosive power needed for sports?
Well, isokinetics enables what we call velocity spectrum training. You can exercise muscles at a wide range of different speeds, from very slow to extremely fast. This is vital because it helps recruit different muscle fiber types, particularly those fast twitch fibers critical for explosive athletic performance. This kind of training has the potential to significantly boost muscle power, enhance the quickness of force development, improve things like time rate of torque development, TRTD, torque acceleration energy, TAE, and overall rate of force development, RFD. All of these are absolutely paramount for an athlete to get back to cutting, jumping, sprinting effectively and safely.
So it's not just about getting strong. It's about getting explosively strong.
Yeah.
And functionally reactive.
Precisely. And there are significant neuromuscular benefits, too. Exercising at faster, reciprocal angular velocities, like rapidly switching from knee extension to flexion, can actually decrease reciprocal innervation time, or RIT. That's the time it takes your nervous system to switch signals from activating one muscle group to relaxing it and contracting the opposing one.
Like coordinating muscles quickly for agility moves.
Exactly. Think about the rapid, coordinated contractions needed for cutting, pivoting, dodging in sports. A faster RIT means quicker, more agile, more coordinated movements. We're talking about that crucial ability to react instantly on the field.
That makes perfect sense. And what about joint health itself? Are there any specific benefits there, especially for a knee that's already been compromised?
Yes, this is a very important and often overlooked benefit. Isokinetics can actually decrease joint compressive forces at higher angular velocities. It's based on principles like Bernoulli's principle and the fluid film lubrication model. Essentially, the faster cartilage moves over synovial fluid, the better the lubrication, reducing compression on the joint surfaces. Clinically, this translates into a remarkable advantage. You can often start rehab for patients with sensitive patellofemoral issues at higher speeds. This reduces their discomfort and protects the joint surface, whereas slower, higher load exercises might actually make their pain worse.
That's a fantastic practical tip for managing specific conditions. Are there other physiological effects we should be aware of?
Definitely. There's this fascinating concept called physiologic overflow. For instance, training at, say, 30 degrees per second can physiologically overflow and provide strengthening benefits even at slower speeds you're not directly training. It allows for broader adaptations. Similarly, there's a 30-40 degree ROM strengthening overflow for short arc exercises. So you don't necessarily have to train the full range to get benefits across a good portion of it. It speaks to the efficiency. And from a practical standpoint, the computerized and real-time feedback from these machines is invaluable. Patients can visually track their progress, see their force output, understand the quality of their movement. It greatly improves their torque control accuracy and keeps them highly motivated, which is huge in long rehab processes.
And specifically for ACL rehab, how does it directly help with protecting the graft? That's always a major concern, right? Especially early on.
Yeah. For ACL rehab, this is maybe one of its most important features. Using short arc testing, or critically, using a proximally placed pad on the shin during knee extension can significantly decrease anterior tibial translation. Minimizing that forward shin movement is paramount for protecting the healing graft, especially in the early and mid phases. This level of precise control over joint forces and the range of motion is a distinct advantage that many other forms of open chain exercise just can't offer reliably. It makes it a powerful tool for safe, progressive loading.
Right. But every tool has its trade-offs, doesn't it? While the advantages are incredibly compelling, what are the limitations we need to be aware of as clinicians? How do we mitigate them?
That's an important and responsible question to ask. One key limitation is that it's primarily used for isolated muscle group testing and rehab. While incredibly beneficial for building that foundational single joint strength, it doesn't fully replicate the complex multi-joint, multiplanar movements we see in real-world sports. Though it's worth noting, some sources mention total leg strength, or TLS, testing, which does try to look at the whole kinematic chain.
So it's not truly functional in the sense of mimicking, say, a jump shot or a complex cutting maneuver on its own.
Not directly, not in that global sense, although numerous studies have shown strong positive correlations between OKC isokinetic test results and functional performance measures. There is a link. It's also true that the velocities used, even the fast ones, might not truly replicate the extremely high speeds seen in actual sports. Those often involve a complex summation of velocities across the entire kinetic chain. Another point, we mentioned increased joint compressive forces can occur at slower speeds, so you need to be mindful of that with patients who have specific joint issues like advanced OA or acute PF pain. And finally, yes, there's potential for increased anterior tibial translation if you use full ROM without proper control. But as we discussed, that can be largely mitigated with specific techniques limiting the range using that proximal pad placement. The key is understanding these limitations and integrating isokinetics intelligently within a broader, more functional rehab program. It's about a holistic approach.
That's a good, balanced view. So to make sure our results are consistently reliable and clinically meaningful, what are the absolute standard steps, the nuts and bolts of setting up and performing an isokinetic test properly? Consistency seems absolutely crucial here for data validity.
It truly is. Reproducibility is paramount for making accurate clinical calls and tracking real progress. First, and this is often overlooked, always thoroughly verbally educate the patient. Explain the task, what they should expect, what maximal effort really means in this context, how the machine responds. Allowing them a few practice reps has been consistently shown to significantly boost maximal effort during the actual test, sometimes from 60% up to 80% or more, just because they get comfortable and confident with the movement and that accommodating resistance.
So an informed patient isn't just compliant, they actually perform better on the test.
Absolutely. Next, always consistently test the non-involved extremity first. This isn't just for establishing a baseline comparison, though that's important. Critically, it lets the patient experience the movement and understand your expectations without the apprehension of pain or vulnerability in their involved leg. It's a powerful demonstration of what a maximal effort should actually feel like, and always maintain the exact same test order every single time you retest for maximum reproducibility.
What about warming up? Is a general warm-up enough, or do we need something more specific right before the isokinetic test?
Warm-ups are critical, and they're really broken down into two essential types. You need a general warm-up, at least 10 minutes of cardio that broadly engages the body part you're testing. For the knee, an upper body cycle or even light stationary cycling often works well. Then, and this is crucial and sometimes missed, a pre-speed warm-up. This involves doing 3 submaximal efforts, maybe 25%, 50%, 75% of perceived max, followed by 1 maximal effort at each specific speed you plan to test. This primes the specific muscles, gets the patient familiar with the different velocities, and recruits the necessary motor units.
And the equipment itself, any critical setup points there?
Always ensure the equipment is properly calibrated per the manufacturer's guidelines. And make sure the dynamometer is stable, away from busy clinic traffic. These machines are sensitive, vibrations can affect readings. Then, meticulously position and stabilize the patient. Use snug but not overly tight straps across the chest, pelvis, and thigh. Prevent any accessory movements or compensations. This ensures the torque measured is only from the target muscle group, not from body sway or other muscles jumping in.
What about during the test itself? Any specific cues or feedback strategies that help optimize performance and consistency?
Yes. During the test, use consistent verbal commands. Simple, clear cues like push and pull as hard and fast as possible work really well, and maintain absolute consistency in your verbal encouragement throughout the whole test. As for visual feedback, it's generally great for motivation during training, but during actual testing, you need to be a bit careful. While motivating, some patients might fatigue quicker trying to match previous reps, or they might unconsciously give submaximal effort if they see they're falling short. So it's a balance. Sometimes limiting visual feedback during assessment gets you a truer maximal effort.
Okay, in terms of the actual test parameters, what speeds, what angular velocities do you typically use for knee testing? And how many reps are standard to get robust data?
Well, the traditional view considers slower speeds, like 60 to 120 degrees per second, as mainly assessing strength. Faster speeds, say 180 to 300 degrees per second, are often linked more with endurance and power. For standard knee testing protocols, we typically recommend a set of 5 reps at 60 degrees per second, then 10 reps at 180 degrees per second, and finally 15 reps at 300 degrees per second. The key here, again, is unwavering consistency in the speeds and reps you choose, so you can accurately compare tests over time. These specific numbers aren't arbitrary. They're designed to rigorously test different aspects of muscle performance, foundational strength, endurance, and power as speed increases. Each serves a purpose in building that complete picture at this stage of healing.
And I've heard of something called gravity effect torque, or GET-T. Can you explain what that is and why it's so important for accurate measurement?
Gravity effect torque, GET, yes, it's a crucial correction factor. It accounts for the torque produced just by the weight of the limb segment itself, plus the machine's attachment. It's measured by the dynamometer with the limb relaxed moving through the full range. This GET value is then mathematically added to movements against gravity, like quad extension, and subtracted from movements assisted by gravity, like hamstring flexion. This process gives you an unbiased, true torque value reflecting only the patient's muscle output, not their limb weight. It's vital to measure GET through the whole ROM each time you test because it can be subtly affected by things like edema, swelling, or muscle atrophy, all things that change limb weight. This ensures an accurate, individualized assessment every single visit. These guidelines, while detailed, are truly crucial for any sports medicine professional to implement immediately for consistent, reliable data. They give you a true picture of your patient's progress. Hashtag the phased approach to ACL rehabilitation with Isokinetics.
All right, moving into the rehab journey itself, let's start right at the beginning. The pre-surgery phase, right after injury, and then immediately post-op in phase I. What's our mission before surgery, and how does isokinetic testing lay the critical groundwork for the whole process?
Okay, so in that pre-surgery phase, post-injury, but before the actual repair, our goals are really multifaceted. We want to mentally and physically prepare the patient for the, let's face it, arduous journey of rehab and surgery. Crucially, we use this time to quantify their physiological baseline. What do their strength and function look like before surgery? That becomes their personal gold standard. We aim to regain as much knee ROM as safely possible, diligently reduce swelling, and strengthen the knee muscles, especially the quads, to try and mitigate that post-op inhibition we know is coming. We also use this time to identify any specific needs, maybe compensatory patterns or potential problems that could complicate recovery down the line.
And for the specific evaluation in this pre-surgery window, how do we use isokinetics or related tools to gather that foundational data?
Clinically, we do a thorough history, meticulously assess pain, swelling, patella position, and mobility. We check both active and passive ROM. Critically, we perform a joint laxity test using an arthrometer. This quantifies that anterior-posterior tibial displacement bilaterally, giving an objective measure of the ACL's integrity compared to the healthy side. For isokinetic testing specifically, if the patient can comfortably do ADLs without significant issue, and your clinical judgment supports it. We conduct a bilateral isokinetic 3-speed evaluation, the protocol. 5 reps at 60 degrees sec, 10 at 180, and 15 at 300. Performed through their full active ROM with instructions for max effort. This gives us that pre-injury baseline for strength and power across the velocity spectrum.
But what if full isokinetic testing isn't really advisable at this point, maybe due to pain or significant swelling or instability?
That's a very practical consideration. If acute symptoms make full isokinetics unsuitable, we opt for a bilateral isometric 3-position evaluation. This involves 5 reps of 5-second holds at 30, 60, and 90 degrees of knee flexion for both extension and flexion. It still gives objective, angle-specific strength data, just without the dynamic movement. We also include a bilateral open kinetic chain proprioception test using the Biodex system for active and passive positions since 5 reps at 60, 10 reps at 180. This checks their joint position awareness. And balance is critically assessed to bilateral and unilateral stance tests, maybe 5 20-second trials. This comprehensive baseline, even if isometric, is invaluable for setting realistic goals and tracking changes post-op.
All right, now, immediately post-op, we're in phase I, focusing on reducing those acute symptoms, typically weeks 0 to 3. Things are incredibly delicate here with the fresh graft. How do we progress carefully while rigorously protecting that graft and initiating early recovery?
Okay, the goals in phase I are absolutely paramount and non-negotiable. First and foremost, protect the graft. Careful management of ROM and forces is key. We aim to get full passive extension 0 degrees as quickly as possible to prevent contractures. Those are notoriously tough to fix later. We also need to allow for proper wound healing, diligently reduce pain, effusion, swelling. ROM targets are PROM 0 90 degrees and OROM at least 20-70 degrees, actively working to avoid flexion contractures. Ambulation starts with 2 crutches, brace locked at 0 degrees, progressively increasing weight bearing as tolerated, ideally to full. Strength-wise, we want to see a good quad set isometric hamstring strength, less than 35% deficit compared to the other side, and objective joint laxity less than 3 millimeter variance from uninvolved, checked with the arthrometer.
That's a significant amount to cover in such an early sensitive phase. How do you evaluate these goals clinically and with those early isokinetic-related tools?
Clinical evaluation in phase I is meticulous. We verify home program compliance, constantly monitor pain, any signs of hemarthrosis or effusion, palpate soft tissues, check patella mobility, track ROM. Most importantly, we evaluate the quality of quadriceps voluntary contraction, that crucial ability to fire the muscle and note any spasm or guarding. At the final visit of this phase, or as soon as medically cleared, we do that bilateral joint laxity test with the arthrometer at 20 pounds, compared to the contralateral knee to assess graft stability. We also conduct a bilateral isometric quad-hem evaluation on the Biodex. Test hamstrings at 30 and 60 degrees, quads at 60 degrees. 5 reps, 5-second holds. Patient generates force as comfortably capable, respecting pain and healing.
And for treatment options within this phase, specifically those related to leveraging isokinetics or the Biodex system for that controlled progression.
In phase I, the focus is gentle, controlled movement and neuromuscular reagitation. We use the Biodex multi-joint system in passive mode for PROM and active-assisted ROM. Knee extension flexion, 0-90 degrees, very slow controlled speed, maybe 2-10 degrees sick. Crucially, the patient isn't strapped in and is told not to resist. It's just pain-free ROM progression guided by the machine. For quad strengthening, primarily isometric holds at 30, 60, 90 degrees. If a patient struggles with a good quad set or shows signs of patella infera due to inhibition, we might use NS, neuromuscular electrical stim, with biofeedback to help activate the muscle and break through that early inhibition. We also begin using the Biodex closed chain attachment for terminal knee extensions from 40 degrees flexion to full extension. Start in passive mode, 5-10 degrees sec, focusing on neuromuscular control, activating the VMO. For hamstrings, Biodex for multi-angle isometrics, 15 to 90 degrees, or active assisted knee flexion in passive mode at 30-60 degrees sec. This careful approach ensures graft protection while starting controlled strengthening and vital neuromuscular read.
Okay, now moving into phase 2, typically weeks 3 to 6 post-op. We're building on that initial delicate foundation. The patient should be showing clearer signs of healing. What are the key milestones we're aiming for here, and how do our isokinetic goals adapt?
Right, phase 2. Goals are to continue graft protection confidently while aiming for more robust ROM. We want active ROM, 0-90 degrees, passive ROM, 0-115 degrees. Wound healing should be complete, sutures out, swelling well controlled, minimal or no effusion. Pain managed without narcotics. Patient should be ambulating with just one crutch, brace still locked at 0, able to fully weight bear. Strength targets: isometric quad strength, less than 60% deficit. Isometric hamstring, less than 25% deficit compared to the uninvolved side. Joint laxity, ideally less than 2 mm variance from uninvolved, and importantly, no more than a 2 mm change from the previous measurement, indicating graft stability.
How does the evaluation in phase 2 differ from phase 1, and what new isokinetic tests get introduced?
The clinical evaluation mirrors phase I, but with more emphasis on ROM progress, really getting that 0-degree extension, and a more critical look at quad contraction quality at multiple angles, especially terminal extension. At the final visit of this phase, repeat the bilateral joint laxity test, arthrometer 20 pounds, to monitor graft integrity. Also perform the bilateral isometric quad eval on the Biodex, HS at 30-60, QU at 60, 5 reps by 5 sec. A significant new addition, often overlooked but crucial, is non-weight-bearing proprioception testing. We use the Biodex system for passive and active position sense. We assess 3 sets of 10 reps with a 10-second hold at target angles 90, 60, 30 degrees. This helps objectively quantify their joint position awareness and ability to reproduce angles, foundational neuromuscular control.
And the isokinetic-related treatment options in phase 2, how do they progress beyond the very gentle approach of phase 1?
We continue with PROM and AROM using the Biodex passive mode for knee extension flexion, gradually progressing ROM to 0, 1, and 15 degrees and increasing the passive speed to maybe 20, 40 degrees sec as comfort allows. Stationary cycling can now be confidently started once knee flexion hits 90 degrees. Often use a Biodex BioStep semi-recumbent elliptical, gradually decreasing speed to 60 RPM as they tolerate resistance. Quad strengthening continues with isometrics, Thasir 6090. We also keep using the Biodex closed chain attachment, 40-degree flexion to full extension, now integrating active-passive or isokinetic modes at 20, 40 degrees sec, still emphasizing strength and neuromuscular control in terminal extension. For hamstrings, continue multi-angle isometrics and introduce active-assisted knee flexion in passive mode at faster speeds, specifically 180 and 300 degrees sec for flexion and 30 degrees sec for extension. This phase focuses on building a stronger foundation of isolated strength and improving that fundamental neuromuscular control and joint position sense.
Okay, now we're picking up speed, integrating more weight bearing, looking for significant strength gains in phase 3, typically weeks 6 to 12 post-op. This is where we start pushing for more robust capacity. What are the key goals and evaluation points here, particularly for isokinetic assessment?
Right, phase 3. Goals become more demanding, reflecting better tissue healing and patient confidence. Continue meticulous graft protection. Aim for AROM 0-125 degrees, PROM 0-135. Patients should be completely pain-free through full ROM during daily activities with absolutely no effusion or swelling, should be ambulating unassisted, maintaining full weight-bearing, normal gait. We want laxity stable, below 2 mm variance from uninvolved and from previous tests. Stability index on Biodex balance, bilateral stance, should hit at least 70% of normative value, showing improved balance. Critically, strength targets: quad deficit less than 40%, so LSI 60% or higher, hamstring deficit less than 20%, and HQ ratio greater than 80%.
And how do we evaluate these critical progress points, bringing in more comprehensive isokinetic measures now?
Clinical evaluation continues. Monitor pain, effusion, patella, ROM, quad control, especially terminal extension quality. Final visit of this phase. Repeat bilateral joint laxity test. Graft stability check. Perform bilateral isometric quad-ham eval, track specific angle strength. A significant and important addition here is the bilateral isokinetic quad-ham 2-speed evaluation. We test at 180 and 300 degrees per second. Now, to protect the graft at this stage, we usually limit the ROM from about 110 degrees flexion down to 40 degrees extension. We avoid full terminal extension with these high loads just yet. Protocol: one set of 10 reps at 180 degrees, one set of 15 reps at 300 degrees. These speeds assess muscle endurance and power, which are becoming more relevant. We also do a gait evaluation on the Biodex gait trainer, speed, symmetry, and test bilateral stability on the balance system, dynamic balance level 8.
What about the isokinetic-related treatment options in Phase 3? How do we leverage the machine's capabilities to meet these more advanced strength goals and start integrating more functional demands?
We continue dedicated ROM work, Biodex passive mode, 0, 115 degrees, 10, 20 degrees for flexibility. Stationary cycling remains core for cardio and knee flexion, a crucial step. Introduce weight-bearing proprioception on the Biodex balance system. Start bilateral stance, dynamic balance level 8, progress towards level 4. Perform 5 30-second bouts. This challenges balance and control in a functional, weight-bearing way. Non-weight-bearing proprioception also continues. Biodex multi-joint passive-active JPS 3x5 reps, 10-sec holds, targets 90 down to 0 degrees in 15-degree increments. For targeted strengthening, quads progress with isometrics, 306090. We also significantly advanced the Biodex closed chain attachment, 40-degree flexion to full extension. Now confidently integrating passive or isokinetic eccentric conic modes at 40-60 degrees sec. These speeds mimic gait, focusing on controlled movement. Hamstring strengthening, Biodex multi-joint in passive mode, 30-60 degrees sec, controlled 10 foot-pound torque, or active assisted knee flexion with higher speeds, 1 under 300 degrees sec flexion, 30 degrees sec extension. The goal is building significant measurable strength and control in this intermediate phase, getting them ready for higher level activities next. #tag advanced progression and critical decision making.
All right, we're now deep into advanced strengthening in Phase 4, typically weeks 12 to 20 post-op. At this stage, we're really pushing for near maximal capacity and function. What does success look like here, and how do we measure it rigorously with isokinetics and other objective tests?
Okay, phase 4. Goals get quite demanding now, reflecting robust graft healing and the patient's increasing functional capacity. Continue vigilant graft protection. Aim for full, maintained AROM-PROM, 0, 12, 50, 135. Critically, pain-free ADLs, absolutely no effusion. Ambulation, completely unassisted, equal step length time, symmetrical gait. Laxity stable, less than 3 millimeter variance from uninvolved, confirming graft integrity. Stability index, Biodex balance, should reach 80% of normative for bilateral stance. Most importantly for return to activity. Quad strength deficit now less than 35%, hamstring deficit less than 6%, and HQ ratio greater than 85%. These are significant jumps, reflecting real gains in muscle capacity.
And for the specific isokinetic testing in this phase, how do we adapt it to reflect these higher demands but still ensure safety?
At the final visit of phase 4, we repeat the bilateral laxity test and isometric quad ham evol to track changes. For dynamic isokinetic strength, bilateral quad ham 2-speed evaluation at 180 and 300 dig sec. Crucially, at this stage, we often continue using a proximal pad to minimize potential anterior tibial translation, and the ROM is typically still limited, maybe 110 degrees to 40 degrees flexion. Protocol: 1 set of 10 reps at each speed. We also meticulously reevaluate gait, Biodex gait trainer speed, step length symmetry, and reassess bilateral stability, Biodex balance system dynamic balance level 8. This comprehensive testing helps pinpoint lingering deficits before moving to high-impact stuff.
How do the treatment options in Phase 4 leverage those isokinetic capabilities to achieve these advanced strength and power goals, really bridging the gap towards athletic movements?
Quad strengthening now includes the Biodex closed chain attachment, 40-degree flexion to full extension, in isokinetic mode at 60 degrees sec, maybe 3 sets of 10 reps, controlled maximal loading through a functional range. We also heavily use the Biodex multi-joint system for open chain knee X-flex isokinetic mode, specifically targeting that 110 40-degree ROM with higher speeds 180 and 300 degrees sec, maybe 2 sets of 10 reps. For hamstrings, we progress on the Biodex multi-joint for knee flexion, now extensively using isokinetic, concentric, eccentric conic modes. This means they actively flex concentric, then resist the machine extending the knee, eccentric. Flexion speeds at 60, 180 degrees sec, critical eccentric extension speeds at 30, 60 degrees sec, build eccentric control vital for deceleration in sports.
And building endurance. Sustained power. How does isokinetics play a role there?
Isokinetic endurance training for quads gets introduced significantly here. We aim for maybe 3 sets of 20-30 reps at 100 to 140 dig sec, pushing towards 70% max effort, build sustained power and fatigue resistance. proprioception, weight bearing on the biodex balance progresses significantly. Move to unilateral stance, dynamic balance level 2 progressing to level 1. 3 sets of 30 seconds building to 3 minutes continually. Add challenges like eyes closed or visual tracing exercises to really push balance and neuromuscular control on one leg. Non-weight-bearing proprioception also continues, biodex multi-joint. Finally, orthosis discontinuation is seriously considered now, but only based on objective criteria. Stable laxity for 4 weeks in an aerobic program, no giving way reports, and meeting those objective strength and balance measures we just discussed.
Okay, phase V, typically weeks 20 to 28 post-op. This sounds like it's about truly honing strength, power, stability. What are the definitive signs we're looking for that indicate readiness for high-level sports-specific activity? Almost full recovery?
This is really where we see the final critical gains, the difference between a strong knee and an athletic knee. Goals: continued graft protection, maintain pain-free ADLs, full ROM, full weight bearing without compensation, laxity consistently less than 3 millimeter variance from uninvolved enduring graft stability. Stability index, biodex balance, now 95% of normative bilateral and importantly 85% unilateral, quad strength deficit less than 30%, hamstring deficit less than 4%, HQ ratio greater than 82%. Finally, open kinetic chain proprioception, active-passive less than 15% deficit, showing highly refined joint position sets.
And what specific isokinetic and functional testing helps us confirm these crucial achievements, clearing them for that next level?
Clinical EVAL continues. Monitor pain, effusion, patella, ROM, spasm. Objective measures: bilateral laxity tests, arthrometer, now at both 20-pound and 30-pound pressures. Check every 3 weeks and at the final visit of this phase. Bilateral isokinetic quad hem 2 speed EVAL, 180-300 degree sec every 4 minutes. ROM still might be limited, 110-40 degrees, 1 by 10 reps each speed. But if clinically indicated and asymptomatic, we might even begin full ROM testing at 300 degrees sec to assess power through the full arc. Unilateral stability rigorously assessed, biodex balance, progress level 8 to 6. And OKC proprioception thoroughly tested, biodex multi-joint for precise neuromuscular control.
How do we use isokinetics in treatment in phase V to really push for peak performance, preparing them for the actual demands of their sport?
Quad strengthening now includes full ROM knee extension on the biodex multi-joint isokinetic mode at very high speeds, 300-500 deg-sec, typically 3 sets of 20 reps, targets high velocity power and endurance, replicating fast concentric contractions. Hamstring strengthening, biodex multi-joint knee flexion isokinetic full ROM, uses intensive eccentric EC-con contractions, away direction eccentric speeds, 60, 90, 120 degree tick, towards direction concentric, 60, 180, 300 deg-sec, builds crucial eccentric strength for deceleration and powerful concentric propulsion. Plyometrics are a significant addition now. Initiate when phase V stability strength goals are met, and the patient can do closed chain exercise and minimal impact running pain-free. Progress from low platforms 4 inches to higher 8-10 inches. 3 sets of 15-20 reps, progressing towards 30 reps. Weight-bearing proprioceptive training continues rigorously. Biodex balance, unilateral, level 8 to 6, 5 bouts of 30 sec progressing to 10 bouts. Integrate functional drills like semicircular and backward running to challenge multi-directional stability. A crucial part, directly influencing return to sport decisions, is the return to running program. Initiate this only when quad deficit is 35%, HQ ratio is 85%, laxity parameters met, and patient is unequivocally without pain, swelling, crepitus, or giving way. Start conservatively. Alternating jog-walk 2.1 ratio forward, gradually introduce backward walking. This systematic progression minimizes re-injury risk while maximizing impact readiness.
This is it. The moment we've all been working towards full return to activity in phase 6, typically 28 weeks and beyond. The culmination of all that precise, data-driven work. What are the definitive criteria for final clearance, full sport participation?
Okay, the final goals for full return are stringent, comprehensive, non-negotiable. Patient must consistently maintain pain-free ADLs, achieve and sustain 100% full ROM, maintain laxity, 3 millimeter variance from uninvolved, complete graft stability, quad strength, less than 10% deficit, hamstrings, less than 0% deficit compared to uninjured limb, full isolated strength recovery. HQ ratio must be robust, 70% at 180 degrees sec, 80% at 300 degrees sec, balanced protective knee. Furthermore, the isokinetic torque curve for both quads and hams should be completely asymptomatic and high quality, that healthy haystack for quads, steep onset for hams. Unilateral stability index 10% deficit compared to norms, bilateral stability well within norms. Finally, functional movement symmetry, rigorously assessed by HOP tests, must be greater than 85% limb symmetry, demonstrates dynamic equivalence.
So a really comprehensive battery of tests to confirm readiness. How do we approach the isokinetic and other functional testing at this final critical stage to ensure nothing gets missed?
Yes, a thorough final eval is absolutely crucial to minimize re-injury risk. Meticulously assess pain, effusion, patella, full ROM, perform bilateral laxity tests at both 20-pound and 30-pound pressures, push the boundaries to ensure robust graft integrity. For isokinetic strength, conduct a bilateral quad-ham 3-speed evaluation, now including 60, 180, and 300 degrees. Importantly, through full ROM at all speeds to show strength across the entire arc. Protocol: one set of 5 reps at 60 degrees, one set of 10 reps at 180 and 300 degrees. Reevaluate unilateral stability, biodex balance, retest OKC proprioception, active-passive for high-level neuromuscular control. Crucially, incorporate a battery of single-leg hop tests. One-legged single hop for distance, one-leg single hop over 24 at 6 meters, one-leg triple crossover hop for distance. Objectively assesses dynamic limb symmetry and power during sport-specific movements. Quantifiable evidence of their ability to tolerate impact and change direction.
And for treatment options, especially related to isokinetics in this final phase, how do we fine-tune their capacity for a safe return to competitive play?
At this point, training demands get intensely individualized, escalated based on the patient's specific sport needs, dramatically increase effort, speed, duration. Both isotonics and isokinetics see significantly increased resistance to meet these specific demands. For isokinetics, we're talking speeds from 180 up to 450 degrees a sec maximal effort, maybe up to 5 sets of 30 reps to really push power, explosive endurance, fatigue resistance specific to their sport. Training becomes highly tailored to simulate game day. Orthosis recommendations carefully considered for activities with potential ACL overstress, especially if any increased laxity is noted, or if the patient expresses apprehension. Running program progresses, full jogging distances to backward running, eventually critical twisting, cutting, jumping. Initially, these higher-level activities, often done with a brace, confidence protection, strict instructions to avoid straight leg landing from jumps. Emphasize proper shock absorption, knee flexion mechanics to protect the graft. This holistic, data-driven approach ensures not just return to activity, but a safe, durable, confident return to competition. #, deep dive into isokinetic data interpretation.
Okay, let's really unpack this part. Once we have all this rich data from our isokinetic tests, all these numbers, these graphs, how do we truly read it? How do we get beyond just the raw scores? What's that qualitative aspect that differentiates, a good clinician from a great one?
This is exactly where the art of clinical interpretation elevates the science. While the reports often, maybe disproportionately, focus on peak torque symmetry and body weight numbers, the first and foremost metric you should meticulously examine is quality, specifically the curve profile. I often tell clinicians, look, I'd much rather see a poor limb symmetry index, a poor LSI, but with a perfectly normal, high-quality strength curve profile than a moderate LSI with a very abnormal, pathological-looking curve.
Really? Why is that?
Because the curve's shape gives you invaluable insight into the amount of underlying pathology, particularly persistent pain, muscle guarding, or that deep neuromuscular inhibition that numbers alone just cannot convey. It's the visual story of their effort and control.
That's a crucial distinction, focusing on the how of the force production, not just the what. So what does an ideal curve profile look like for the quads and hamstrings? And what are the red flags we should be looking for?
Okay, for the quadriceps, the ideal curve profile should resemble a big old haystack, meaning it's large, round, full, indicates consistent maximal force production through the entire available range. It should rise sharply, maintain a plateau, then gradually decline. For the hamstring, the profile is different. Should have a very steep, immediate onset of force, then a gradual decline before a steeper fall-off towards the end of the range. That unique shape is largely due to elastic tension early on and active insufficiency later. Now, red flags. If you see a truncated or crop-topped quad curve where the peak is flattened or blunted, especially at slower speeds like 60 degrees sec, that's a significant warning sign. It tells you there's a serious underlying issue preventing full sustained force generation.
And what exactly does that truncation or blunting tell you beyond just, oh, the peak force is lower? What's the clinical insight there?
It signifies a significant underlying problem. Often indicates a deep-seated neuromuscular or neurological weakness and barrier, something that simply cannot be overcome with traditional resistance training alone. While the 180 degree sit curve shape typically normalizes before the 60 degree sit curve during recovery, if both are truncated, it indicates a profound deficit, suggests a greater, more challenging road ahead in rehab. We also meticulously analyze what we call the 4 areas of a curve. Time rate of tension development, TRTD, how fast they generate force, torque obtainment, the peak force itself, force decay rate, FDR, how quickly force drops off, and reciprocal innervation time, RIT, speed of muscle switching. For instance, a classic sign in ACL-deficient knees, even post-op, is a concavity in the force decay rate around 20-30 degrees of knee flexion. Indicates instability or weakness in that critical range. These visual cues, combined with your patient's symptoms, are invaluable for refining your diagnosis and guiding treatment modifications.
Okay, beyond this qualitative curve analysis, which is clearly so insightful, what are the key quantitative metrics? The numbers we absolutely need to track for objective progression. Let's start with the Limb Symmetry Index, LSI. What's the target, and what are its crucial limitations we need to be aware of?
Right. LSI, commonly used, compares injured limb performance to the uninjured. Our protocol suggests a 12-week benchmark of 60% LSI, meaning we're hoping for less than a 40% deficit. However, achieving high LSI can be challenging, especially with donor site morbidity, if they used a quad tendon or patellar tendon graft. But here's the crucial limitation, and it's a point that can profoundly mislead clinicians. A high LSI doesn't always guarantee true bilateral strength or functional readiness. Patients can, in fact, be bilaterally weak.
Right, we touched on this earlier.
Exactly. Both limbs are equally deconditioned or weak, giving you a seemingly good LSI, maybe 90% symmetry, but neither limb is truly strong enough for high-level activity. That's why solely relying on LSI can give a false sense of security, can potentially lead to premature return to sport. Which brings us directly to our next, more functionally pertinent metric, peak torque to body weight.
Ah, yes, this is where we account for individual differences in patient size and leverage that for functional readiness. What are the target values here, and why is this ratio considered more functionally pertinent than just LSI?
This metric is arguably one of the most vital for making safe, confident return to activity decisions, especially when LSI comparisons might be misleading due to detraining in the uninvolved limb. It's functionally pertinent because it normalizes strength to the patient's actual body mass, the mass they have to move, accelerate, decelerate during activities. Gives a direct measure of their engine power relative to their own body. For females, we're looking for a mean of about 86% of body weight expressed as foot-pounds per pound body weight at 60 degrees sec. The 95% confidence interval is roughly 80-95%. That equates to about 2.6 Newton meters per kilogram. For males 20-50 years old, the mean target is 100% of body weight at 60 degrees sec, 95% confidence interval around 115%, equates to approximately 3.0 Newton meters per kilogram. These aren't just academic numbers, they're your quantitative benchmark for functional readiness. Hitting these means your patient has the raw power to move their own body effectively. Gives us confidence they're building a truly robust foundation for higher demands.
So if a patient hits these numbers and they have a good curve profile, what does that fundamentally tell you about their capacity? And crucially, about your loading decisions moving forward.
This metric, combined with that qualitative curve quality, is precisely what should inform your loading decisions. If the curve profile is healthy and these absolute strength targets relative to body weight are met, it indicates the patient has the fundamental muscular capacity. In these cases, you can progressively load them with confidence. Their quads will likely continue to respond well to traditional progressive resistance. However, if there's an abnormality in the curve profile, that truncated shape, or a large deficit in this absolute strength metric, even if the LSI looks decent, it strongly suggests that neuromuscular or neurological weakness and barrier we talked about. In these critical cases, simply adding more weight or reps in traditional resistance training won't cut it. You need to consider alternative strategies. Submaximal weight with biofeedback, maybe blood flow restriction training, BFRT, to stimulate gains with lower loads, or even NMES at high Russian stim levels to overcome that profound neuromuscular inhibition and truly wake up and strengthen the quads. This is a key, often overlooked insight for clinical decision-making when progress stalls. We also diligently track total work and total work relative to body weight. While maybe less commonly touted in normative values than peak torque, these metrics are exceptionally important. They represent the area under that torque angular position curve, essentially indicating the muscle's sustained ability to produce torque through the entire range. Gives insight into muscle endurance and overall capacity. They're naturally dependent on testing speed, peak torque achieved, and the total arc of motion used. I personally tend to use a slightly larger arc, around 100 degrees, for total work calcs compared to some protocols using 80 or 90 degrees, just to get a fuller picture.
When do we typically start focusing on the hamstring to quadriceps HQ ratio? And why isn't it a primary focus earlier in rehab?
Right, the HQ ratio. We typically don't place significant focus on it in the very early phases. Why? Because significant quad weakness, which is common post-ACL surgery, can artificially inflate the ratio. sometimes makes it look as high as 90%, which is misleading. It becomes a truly relevant and reliable metric to focus on around the 24-week testing mark once the quad strength has shown more significant recovery. However, I personally have an aggressive early goal. By the 12-week test, I aim for the hamstrings to be at 80% LSI or higher.
Why so early for the hamstrings?
Well, as therapists, we have fewer excuses for a weak posterior chain, right? We can usually load those muscles relatively early and often, provided pain and swelling are controlled. Remember, hamstrings are absolutely crucial dynamic stabilizers for the ACL. They act synergistically to protect the graft. Our ultimate goal is actually to create a slightly hamstring-dominant knee by biasing the unilateral ratio, meaning strengthening the hamstrings to maybe 10% higher than the normal unilateral ratio for that specific velocity. Provides enhanced synergistic co-contraction, dynamic stability, adding an extra layer of protection.
You mentioned rate of force development, RFD, as a critical power parameter. You even called it a game changer. How exactly do we test this, and why is it so uniquely important, setting it apart from traditional peak torque measurements?
RFD 2080 is indeed a game changer. It's a secondary test that I typically add around the 24-week testing mark once the patient has established a solid strength base. The protocol, isometric force production at 90 degrees of knee flexion, 3 repetitions. The cue is critical. Push fast and hard immediately upon command. After a few practice trials so they understand that explosive effort. We then measure the RFD specifically between 20% and 80% of their maximum best isometric contraction, MBIC.
Why specifically the 20-80% window, not 0-100% or something else? What makes that specific window better for reliability?
That's a critical question, speaks to the nuances of power testing. RFD is inherently volatile. It can be highly variable if not measured precisely. Using the 20-80% window significantly improves its reliability by avoiding the skewy or less reliable data points right at the start, time 0, and at the absolute peak force. These ends can be affected by things like reaction time or slight variations in peak effort. The beauty and the power of RFD 2080 is that it does not have a strong correlation with peak torque.
So it's measuring something different.
Exactly. If it correlated strongly, you could just measure peak torque. But because it doesn't, it provides truly unique and crucial info about the muscle's ability to produce force quickly, which is distinct from just how much force it can produce. It's the speed of the engine, not just its max horsepower.
What are the normative values you look for with RFD 2080, especially normalized to body weight? And what's its profound clinical significance for return to sport?
When normalized to body weight, my personal clinical cutoff for initiating safe, low-level jogging is a value of 3.0. That's foot-pounds per pound body weight per second, or roughly watts per kilogram. That's considered good enough. A value of 4.0 is great. For LSI and RSD 2080, 70% is good, 90% is better. Though it's common for this RFD LSI to lag behind peak torque LSI, power usually comes back later than raw strength. The clinical significance for return to sport is immense. It's a much stronger correlate to crucial functional performance parameters like the knee extensor moment, optimal knee flexion angle during running, jumping, landing, than traditional peak torque measurements alone.
So hitting this RFD criterion truly gives you a high level of confidence to initiate those higher impact activities, like plyometrics.
Absolutely. Meeting this criterion gives me the confidence to start low-level plyos, allows me to sleep at night knowing the patient has developed that critical explosive readiness. It's the difference between being strong in the gym and being agile and resilient on the field. However, it's not the only factor. If, for example, a patient's knee flexion angle on the treadmill is just, say, 30 degrees of excursion indicating poor mechanics, a stiff knee landing, despite good RFD numbers, clinical modifications are still absolutely necessary. We must ensure long-term knee preservation, optimal biomechanics. Emphasize not becoming prisoners of the moment and overlooking underlying biomechanical issues just because the numbers look good. Combine objective data with nuanced clinical observation. A few other advanced considerations for a really comprehensive assessment. While less common in standard protocols, the concentric quadriceps to eccentric hamstring ratio can be valuable, especially for certain hamstring-dominant demographics. Look for a specific difference, maybe 1.4, 1.2 for balanced function. As for eccentric quadriceps testing, personally, I rarely incorporate it in a standard, aggressive way.
Yeah, I can imagine that sounds pretty intense, potentially risky. Why the reluctance, and what alternatives do you find more clinically viable for assessing eccentric strength?
It is an aggressive test. Can be quite difficult for patients to perform correctly, needs high confidence, and often has a high coefficient of variance, CV, meaning less reliable data. More importantly, it carries a higher potential for patient confusion or even re-injury if not done perfectly. Instead, for assessing eccentric capacity, I prefer a modified interrupted stroke test done in passive mode. Here, the dynamometer moves the limb passively, and the patient is told to push or pull against it to engage the quad or hamstring eccentrically at specific points. Provides a safer, more controlled assessment of eccentric strength and control, even though it's not standard biodeck software and requires manual implementation and careful clinical judgment.
And finally, a quick clarification. Why specifically 90 degrees of knee flexion for that RFD isometric testing, not other angles like 60?
Good question. Few key reasons for standardizing at 90. First, the established RFD 2080 normative values we use as benchmarks, they're normalized to 90 degrees, gives a consistent reference point. Second, a pre-stretch on the extensor mechanism at 90 degrees often facilitates better, more powerful force production from the quads. Finally, even with proper setup, the anatomical knee angle can subtly change, maybe 10-15 degrees, during an isometric contraction. At 90 degrees measured flexion, the tested angle of peak torque in a healthy quad usually falls in the high 60s or low 70s. That's generally where peak torque naturally occurs for the quads anyway, makes it functionally representative. And just to reiterate, 60 degrees per second testing. Excellent standalone screening tool for baseline metrics, especially non-op cases. If you're limited on time or equipment, it really offers the biggest bang for your buck for a quick but meaningful strength deficit assessment. #tag outro.
We certainly covered a lot of ground today, from tracing those historical shifts in ACL rehab to providing a really meticulous, phased approach to integrating isokinetics. It's abundantly clear how the sophisticated testing provides objective, actionable data that can guide precise interventions at every single step of a patient's recovery journey.
Indeed. We've emphasized the critical role of qualitative curve analysis, how to truly read those haystack and steep onset profiles, because the shape of the curve often tells you more than raw numbers alone about underlying issues, inhibitions. Then we delve into the precise quantitative metrics, the nuanced interpretation of LSI, the critical importance of peak torque to body weight, the protective HQ ratio, and of course, we unpacked the game-changing rate of force development 2080, which provides those crucial insights for making confident, informed, and ultimately safe decisions for return to high-level activity.
Remember, by applying this comprehensive step-by-step masterclass approach, you, the sports medicine professional, can immediately implement and refine your testing procedures and protocols. Throughout that entire first year of rehab following knee surgery, this will lead to more robust, more predictable, and ultimately more successful outcomes for your patients, getting them back to the activities they love with confidence and hopefully resilience.
Consider this. In a world absolutely inundated with numbers and data, the true mastery of rehabilitation lies not just in diligently collecting those metrics, but in discerning the subtle, often hidden narratives within those force curves. What further, maybe groundbreaking insights might you unlock by truly listening to what your patient's knees are telling you at every degree of motion and every millisecond of force production?
Powerful questions for continued exploration. We hope this deep dive has not only given you plenty to think about, but more importantly, armed you with tangible, actionable strategies to apply directly in your practice starting today.